Good afternoon and welcome. I'm Tom Moore, Media Relations Director with UI Healthcare. We're glad you have tuned in to learn about back pain symptoms and causes, herniated discs, pinched nerves, and treatment options. Before we begin, I have a couple of housekeeping items. We invite you to use the Submit a Question box to ask our presenter a question during the webinar. Questions will be answered at the conclusion of the program as time allows. Check our website, www.medicine.uiowa.edu/community for upcoming educational programs across the state of Iowa for children and adults. Now, let's introduce our presenter. Cassim Igram, MD, is a clinical associate professor in the Department of Orthopedics and Rehabilitation. He has more than 21 years of experience as an orthopedic surgeon. Now, let's begin our presentation.
Well, good afternoon. I'm Dr. Cass Igram, and we're going to be talking about back pain today. I'm a clinical associate professor here at the Department of Orthopedics at the University of Iowa. So low back pain is a pretty common condition. In my clinic, we see a lot of people that have back injuries, that have back pain. Typically, it's related to the soft tissue structures that make up the spine, the muscles, ligaments, and the discs. Most people will typically get better on their own. We'll do different symptomatic treatment for their complaint. Many times it may or may not be associated with an injury. More often than not, we don't have a specific injury that leads to somebody coming to see us with back pain. But the typical history for back pain is usually pretty benign. Most of the back pain that we see is so-called mechanical low back pain related to activity. This is the most common form of back pain that we see in the clinic. I put on there as the second point visceral pain, which is also referred to as non-mechanical low back pain. This could be, for instance, somebody who has, for example, an aortic aneurysm that may present as back pain. Or something that could involve some sort of intra-abdominal tumor. Pancreatic cancer comes to mind that can present very insidiously with back pain. So those are things that obviously we want to keep in mind, but most people that we see do have so-called mechanical low back pain. So some interesting facts related to back pain and back injuries. Statistically speaking, it's the second most common cause for people to miss work. Second most common reason for a physician visit. Third most common reason for elective scheduled surgery. And then the costs. 20 to 50 billion annual treatment costs for back pain and back injuries. Annual lost productivity as a result of back pain is about $28 billion. So there's a lot of expense involved. So the initial office evaluation for somebody with back pain, with pain that does not go into the legs, so in other words, they are not having sciatica. And there are many factors involved that can lead to their back symptoms. And there may or may not be an injury associated with it. So some of the factors that are involved are some of the contributing factors. A history of smoking. Smokers tend to have higher incidence of back pain and higher incidence of degeneration of their discs in their back. There's a familial component, meaning there's some family history. Heavy labor tends to be associated with higher incidence of back pain. People with chronic pain tend to have depression. That seems to go hand in hand. And then overall general health. Deconditioning, sedentary lifestyle, obviously those are contributing factors as well. So cause for concern, and this is what I was referring to earlier with so-called non-mechanical back pain. If somebody comes into the office with a back pain and has a recent unexplained weight loss, night pain, maybe they have a history of cancer or have been treated in the past for cancer, are running fevers, maybe spiking fevers at home, have had a recent illness or of course history of trauma, then those are areas where we would have heightened cause for concern that maybe there's another issue going on besides so-called mechanical or muscular type back pain. So initially, when we see a patient in the office, our first step is we want to take a history from the patient, find out about the onset of their pain, aggravating and relieving factors, what kind of medications they're taking, the location and distribution of their symptoms and the severity of the same. And then, of course, we want to perform a physical exam, see if we can determine if a person has potentially any other red flags that might alert us to another issue besides what we believe is likely mechanical or muscular type back pain. And then after that, we want to obtain appropriate imaging studies. So this diagram, fairly self-explanatory. It shows just a drawing of what the spine looks like looking from the side. We see the vertebral bodies right here. The blue represent the cushioning in between the vertebrae, the intervertebral discs. And then if we look over on the right, this drawing is supposed to represent what a worn down or degenerated disc looks like. And on X-ray, obviously, we would be able to see the same thing. Narrowing of the disc space, bone spurs around the vertebrae that implies disc degeneration. Some of this is representative of an aging spine where we see degeneration of a disc. So the imaging studies that we would choose, typically X-rays are the first step. Patients would come into the office. If they are having back pain, we would get X-rays of their low back. And depending on circumstance, we would typically order an MRI, which is probably the most common advanced imaging study. Or if circumstance prevents getting an MRI, a patient, for instance, has a pacemaker, then a CAT scan would be a secondary study of choice. So a typical MRI scan on a patient, here we see a side view. Here is the spinal sac right here, that white stripe where the spinal nerves are. The kind of gray building blocks are the vertebrae. The stripes in between are the disc spaces. We see a little wear and tear of these discs as evidenced by they're a little bit darker, meaning they're a little bit lacking in water content between the fourth and fifth lumbar vertebrae and the fifth lumbar and the sacrum. This is a fairly typical MRI, and the discs are representative of a spine that, does show some aging. So treatment of low back pain, as I said earlier, for the vast majority of patients, the history is very favorable. Relative rest or perhaps activity modification, anti-inflammatory medications are very appropriate. Physical therapy can be very helpful. I put on this list lifestyle modification, smoking being the most obvious, trying to exercise and improve conditioning, and in that circumstance, many patients will get better on their own. Typical time course can be anywhere from 8 to 12 weeks. No scientific support for, and I get asked questions fairly frequently from patients about all of these treatments that I've listed: acupuncture, chiropractic, dry needling, prolotherapy, traction, inversion tables, and laser treatments. There is no scientific evidence to support any of these treatments, as opposed to simply letting back pain run its course and resolve on its own. Anecdotally, there are a lot of patients who do receive treatment with all of these modalities, and I've seen them in my office. Typically I think chiropractic is probably the most common that patients seek, and no doubt people do seem to get improvement with manipulative treatments. As far as acupuncture and dry needling, traction of the lumbar spine, inversion tables, again, there's no scientific evidence to support it. If a patient says, hey, I'm getting acupuncture and it's helping my back, I typically won't dissuade them, but I usually don't actively encourage people to seek that form of treatment. So having said that, exercise is good, and there is literature to support core strengthening, low impact aerobic conditioning. People who do engage in these activities do tend to get better with their back. And that's somewhat intuitive. That's active treatment that's improving your overall level of fitness. Injections. Another common form of treatment, colloquially these are referred to as epidural steroid injections. In my experience, for people that have predominant complaint back pain, epidural injections are a very limited benefit. And again, usually you're injecting steroid with some sort of local anesthetic. I usually don't refer patients to the pain center for injections for epidural steroid for back pain. And then finally, surgery. Surgery being a last resort for many of the conditions that as orthopedic surgeons that we treat, at least on an elective basis. Surgery in and of itself for back pain has very limited benefit. And of the two options that are available, usually we're either looking at fusion of the involved vertebrae in the disc or disc replacement. There's very marginal success with both of these options in the literature. Disc replacement is somewhat new compared to fusion. I have not performed disc replacement in the lumbar spine myself. I have done fusions for back pain with variable degrees of success. And that's not an operation that I'm performing any longer just because I got really not very good success rate with it. So that's kind of a synopsis of treatment for back pain. And that's one of the more common things that we see in the office. The other more common, or one of the more common conditions that we treat are herniated lumbar discs. Also referred to as a ruptured disc, can be associated with a quote-unquote pinched nerve, meaning a piece of the disc has ruptured out and is pushing into one of the spinal nerves. Patients will typically present with back pain and leg pain, and sciatica is a term that's used quite a lot. Sciatica refers to pain that radiates into the leg. It does not refer to involvement of the sciatic nerve, but it's more of a descriptive term describing leg pain. The evaluation of these patients, same as somebody with back pain. We want to obtain a history from the patient, find out about the onset of their symptoms, the location. We want to perform a physical exam. We want to check to see if there's any numbness or weakness in one or both of the legs. And then we typically want to obtain an imaging study to confirm the diagnosis. So signs and symptoms of a herniated disc. Typically a patient presenting with a herniated disc with a pinched nerve will have leg pain that goes to the foot. They may or may not have some degree of back pain. Common complaints are numbness, tingling, and weakness in the involved extremity. So here's an MRI of a herniated disc. Here's a side view, and then here's a cross section of the spine. The side view, and we see arrows obviously to help us out here, but this is a very large ruptured disc between the fifth lumbar vertebrae and the sacrum. So there's a pretty large portion of disc material poking into the spinal canal. In cross section, we see the same thing. Here's a fairly large piece of disc pushing into and deflecting the spinal sac, which is kind of pushed to the side right here in the spinal canal. I would expect, at least based on this MRI scan, for this patient to have rather significant pain in their left leg. So initial treatment for most herniated discs is typically non-surgical. Anti-inflammatories here again are a good medication choice. Physical therapy is also very appropriate. This is a circumstance where epidural injections are also of rather significant benefit. And the last point that I make on this slide is that most, meaning about 75% of patients, will get better without surgical treatment. The history of a herniated disc is pretty benign, and there are excellent long-term studies that show that if you wait long enough, and there are studies going out 3 to 5 years showing that the results of surgical treatment versus non-surgical treatment of a patient with a herniated disc are roughly the same. So, speaking of surgery, and of course being a surgeon, if we do have patients that come to an operation, I've listed 3 different types of discectomies that are kind of variations on a theme. Essentially, it's predicated on the size of the incision and how much of the spinal canal we're going to open to accomplish our goal. It's nice to be able to use a smaller incision and do a so-called microdiscectomy or a minimally invasive discectomy. Ultimately, though, we have to remove the ruptured portion of the disc that's in the spinal canal. Long term, there is no difference in outcome with any of these 3 operations. Now, having said that, the microdiscectomy is nice because typically that's something that can be done as an outpatient. And same for the minimally invasive discectomy. So what to expect from surgery? Well, again, surgery is usually our last treatment option. If we are looking to relieve leg pain for a ruptured disc, the success rate for that is in the neighborhood of 90%. It is a fairly low risk operation, but as with any operation under general anesthesia, the risks are not zero, and usually it can be done as an outpatient. In my experience, this is about a 45-minute operation. If we have a patient that we do a discectomy on first thing in the morning, we can usually have them as an outpatient home around lunchtime. So, any questions? I think we are set up to take questions over our internet link. So let me open my email browser here and see if we have any questions to answer. So let's see, looks like the first one we have here, do I recommend vitamin D, calcium, chondroitin, and glucosamine as supplements to improve bone health for people in their 60s and 70s? So the answer to that question is chondroitin and glucosamine are actually supplements used to improve joint health. There's very weak literature to support their benefit as far as improving the health of large joints like the hip or the knee. I'm not aware of any literature to support their use for, at least for the spine. Vitamin D and calcium, I think, are important for overall bone health in somebody who is trying to prevent or may have osteoporosis. Obviously, we have other drugs to treat osteoporosis as well, but I think weight-bearing exercise, appropriate use of calcium can help to maintain overall bone health. So one of the other questions that we just got is, does ice or heat work better to reduce pain? And that's actually, from my own personal experience, I prefer ice for muscle pain and muscle spasm. The analogy that I typically use for that is in athletes. You know, if after ball games, like for instance the Hawkeyes are playing tomorrow night, I'm sure some of you may have heard there's a big football game here at Kinnick Stadium tomorrow night at 7. And after a ball game, many of the athletes will use an ice bath. Or the other example is Major League Baseball pitchers. After they come out of a ball game, typically the first thing they do is pack their arm in ice. So I think ice is very good for muscle swelling and muscle spasm as far as a pain relieving maneuver. All right, so let's see here. Good thing I have my glasses on so I can read these. So another question that we just got off the internet, is arthritis associated with lower back pain? The answer is yes, arthritis can be associated with lower back pain. The implication of that is degenerative changes in the lumbar spine, so-called disc degeneration, bone spur formation, arthritis that develops in the joints of the low back. Then yes, that can be a condition associated with low back pain. You know, unfortunately, as people age and their spine ages and they do develop degenerative changes, that's unfortunately part of the process. Some people will develop back pain as a result of it. We do try and treat that symptomatically with low impact exercise and anti-inflammatories. It'd be nice if we could figure out a way to turn back the clock and prevent degeneration of the spine, but you know, unfortunately, nobody's been able to figure that out yet. So let's see, we have another question. So this question reads, if you have been told that you have arthritis, is there any best treatment or medication for this? So the so-called non-steroidal anti-inflammatories I think are a good choice for arthritis. So in my office when I was in Des Moines, we'd get samples of the newfangled arthritis medications that the drug representatives would leave off for us. I've tried different ones over the years for various aches and pains after perhaps I've been working in my yard or doing something that I knew was going to make my back hurt or my joints hurt. And I had to tell you, I think the one that I found over the years that works best for me is plain old Motrin. It's cheap and easy to come by. And I simply will take an 800 milligram Motrin from time to time if I need it. I think it works just as well as any of the other ones. I know Celebrex just went generic, which is also a good medication. It was very expensive. A lot of drug plans wouldn't approve it. And quite frankly, I've used both, and I still think Motrin works best for me. Now, that's my personal experience, but I think as far as treating arthritic type pain in the back, anti-inflammatories are good. Low impact exercise, as I mentioned, is good. A lot of, especially elderly patients, will do pool exercises, which I think is fantastic. I think that's a great way for people to exercise and not have injury. All right, so next question. So a 58-year-old patient who has degenerative and herniated discs, and the concern with this question is that the question is whether he could become paralyzed if he continues to work with degenerative and herniated discs. Does have quite a lot of back pain. He does exercise and doesn't smoke and uses anti-inflammatories. So the answer to that question is, first of all, with regard to paralysis from degenerated discs, that's it would be extremely unlikely for that to occur. Certain activities, obviously talking about labor, can certainly aggravate an underlying back condition. Continuing with the same line of work, yes, could certainly aggravate that on an ongoing basis. I don't know that it would necessarily aggravate or accelerate the degenerative process, but if I have a patient who, for instance, is a heavy laborer, does have an underlying back condition which continues to be aggravated by their work, if they do have an option to try something else, I think that's advisable. Obviously, trying to make some lifestyle modifications I think is appropriate, but again, I think the risk of paralysis in the vast majority of patients with this type of condition is unlikely. So my email is running a little behind here, so let's all right, so another question that just came through. Will insurance cover the surgery, and how much will it cover? So that one's kind of a moving target. I think in general for elective spine operations, obviously before we take anybody to the operating room, we do check with their insurance carrier to see if we do have pre-approval. The vast majority of cases that we are performing are approved by third-party payers, whether that be Blue Cross, United Healthcare, or Medicare. As far as the amount of coverage, it really depends on the insurance plan. If somebody has a health savings account with a high deductible, they're no doubt going to incur a rather significant out-of-pocket expense depending on their deductible. If they're on a pretty good health plan and maybe they have a 90-10 split on their health insurance, or they have first dollar coverage, obviously that's really good insurance. So it really just depends on what your insurance coverage is, what the limits of coverage are, and how much they will cover for an elective case. So let's see, next question. How long does the surgery take? So for instance, a lumbar discectomy or a microdiscectomy, that operation, I think I mentioned a little bit earlier, to remove a portion of a herniated lumbar disc is about a 45 to 60 minute operation. So at least in my experience, that's I wouldn't say a fairly quick operation, but that's fairly short, that we have a patient asleep for a relatively short period of time. Obviously, there are other operations, especially people who've had, for instance, spine tumors or spine trauma. They can be very lengthy cases running several hours, but for a routine elective lumbar discectomy, that's a fairly short case, which allows us to do that as an outpatient. Okay, so Another question that just came through. After what amount of time should I consider surgery to relieve my back pain? So that's a very interesting question, and the answer to that is for people who have straight back pain without any so-called pinched nerve pain or sciatic pain, in general, there really is not a good, at least in my experience, there is not a good surgical solution for straight back pain. As I said earlier in our talk, the surgical options include fusing the so-called degenerative disc by fusing the vertebrae above and below, or possibly doing disc replacement. While those sound attractive, the literature would seem to suggest that the results of those are average at best. And typically it's very hard to make somebody completely pain-free after that operation. The goal of any operation, when it is done for back pain, would be to restore a person to a functional level, but probably not realistically make them pain-free. Well, I'll tell you what, I think we have time for one more question, last one that just came through. What are the non-surgical options that you would recommend to help with back pain? And just, again, touching on what we talked about earlier, I think, at least from a medication standpoint, I try and use anti-inflammatory medications on a regular basis. Typically, I try and avoid narcotics, unless, of course, it's somebody that we have done surgery on, that we need to use narcotic medication in the post-operative period. As I said earlier, low-impact exercise is very good. Swimming, I think, is outstanding. Elliptical, treadmill, inside, usually I try and get people to avoid running, but if they want to do a walking at about a 3-mile-an-hour clip or 3.5 miles an hour in a treadmill, I think that's very appropriate. Core strengthening exercises, also very appropriate. I try and discourage, as I said, people from running outside on the pavement because I think it does aggravate their back. But in general, I think working on core and low impact exercise is very beneficial. All right, well, it looks like we really don't have any further questions coming through on our over the internet. So having said that, as you can see, our last picture that I had displayed on the internet is that's from the Hawkeyes' victory over Penn State from 2009. For anyone who was at that game, it was very cold, but having the Hawkeyes win on the last play of the game certainly made it a lot warmer. So everybody enjoy your weekend, and obviously go Hawks.
Please keep an eye out for an email from us within the next 2 days, which is a program survey. You will also receive a follow-up email with information and links from today's presentations. Thank you again for attending the webinar, and we look forward to seeing you at future programs.